Evening, everybody. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Welcome to our webinar tonight, Veterans Connect. I'll just do a little bit of housekeeping before I hand over to Melissa. If you have any questions, please don't hesitate to type them into the question box, and Melissa will try and keep her eye on them while Eleanor is presenting. We also have Erica Drew here tonight, who's our Health Pathways Manager at the Central Coast, and she will do a quick presentation at the end just to talk about health pathways. This is being recorded and we will put a copy of it in our calendar, not in our calendar, in our library, along with a PDF copy of the slides. I think that's about all you need to hear from me. I will hand over to Melissa.
Thank you, Jenny, and welcome everybody. Before we start and introduce ourselves, I would just like to acknowledge that we respect and honour Aboriginal and Torres Strait Islander elders past, present and future. We acknowledge the stories, traditions and living culture of Aboriginal and Torres Strait Islander people on this land. I would like to acknowledge that I am working tonight on Awabakal land, and also welcome any of our First Nations colleagues into the meeting tonight. Firstly, just to introduce myself before we introduce the wonderful Ellie, who is going to do a wonderful presentation for you tonight. My name is Melissa Wiseman. I work for Social Futures and support the Veterans Connect program. And we'll hand over to Ellie to introduce herself and to commence the presentation.
Hi everybody, I'm Ellie. As Mel said, I'm the team leader for Veterans Connect here on the Central Coast. And I'll flick through some of the slides there. I've done the acknowledgement to country. Thank you, Mel. And I guess I'll just jump right into it. So who are we? We are Veterans Connect. We started at the beginning of last year, and we're a little team of 3. So it started as myself as a care coordinator, another care coordinator and a team leader. That team leader's moved on, I've stepped up, and we have a new care coordinator coming on board. We have some amazing experience between the 3 of us, a lot of mental health experience, a lot of disability experience across the veteran space, and also the NDIS and my aged care space as well. So we've got a lot of strengths that we're bringing across to the veteran space at the moment. So a little bit about us as a program. We're a pilot program and we're funded by the PHN. We were founded in response to the preliminary findings for the Royal Commission into veteran suicide rates. I'm sure everybody's aware that's been an ongoing thing for quite some time, and it's been quite a big fixture in the media whenever it comes up. So the PHN put together a bit of a plan for this so that we can actually be supporting our veterans instead of waiting to see what the final findings say. So they noticed that there was a gap in services for veterans where there was nobody helping them to connect. It was quite difficult for veterans to then step into the space and find the providers that they needed. I'm not sure if everybody's familiar with how tricky the DVA can be to navigate, but you know, once they're given the okay to go ahead and receive treatment, it's very difficult for people to then find the providers. So we noticed that was a very, very big barrier for people actually accessing those services. So that's what our job basically is. We're that connector. We're there basically to just reduce the veteran suicide rate and the severity of mental illness amongst the veteran community, as the slide says. We provide non-clinical care coordination to our participants, and we use a range of different sort of models to deliver that care. So every single person that we get in is completely different, and we make sure that we adjust our level of care and how we provide that care depending on the circumstances for each person. So far, we've had some really great results. We can show that we've had quite a reduction in the severity of distress in the people that we've been supporting, which has been fantastic. So the areas that we operate in, so obviously we're funded by the PHN, so we generally sort of stick to the PHN areas. We started on the Central Coast because according to the, I think it was the 2016 census data, the Central Coast had the highest veteran population. It is the ageing population that we mainly have here, so we do have a lot of older people that are on the aged care pension, accessing DVA services that way. But we do have a lot of younger veterans as well, and we found that the Hunter region was also quite full, and there was quite a need. We could show that we were doing quite well, and so we've expanded at the beginning of this year, which is very, very exciting. We're now based out of Gosford and Maitland, and while we try and service as much of the PHN sort of demographic area as we can, some of our service delivery will have to be remote, so via phone or Teams or however we can support somebody if it's a little bit too far out the way. Probably worth mentioning our wonderful no wrong door policy. It's one of my favourite things about our program is that no matter who is referred to us and who comes in for help, whether they're out of area, whether they're suitable or not, we always try and find them some sort of support. We don't just sort of turn people away and go, sorry, we're not the right service for you, you don't fit our nice neat little box. We genuinely look at how we can help somebody and connect them to whatever services we can without sort of overstepping, obviously, but it's really lovely to be able to provide that genuine care. So who do we support? So any ex-serving ADF members, any that are currently serving but they're in the process of transitioning out, so they might be medically transitioning, they might have had an injury or an illness or a mental illness that they're struggling with and they're trying to transition back into their sort of normal everyday lives. And we found that it's quite challenging for people to leave that that space where everything's catered for in-house. So there's doctors, there's specialists, there's dentists. They don't have to really think about where to find the people. They just sort of put their hand up and go, this is what I need right now, and it's done for them. So it's quite challenging for people to step out of that space and have to find all of these things for themselves. And statistically speaking, the window of I'm pretty sure it was 2 years, 2-year window after people have left is the most dangerous window for people for attempting and completing suicide after they've left. So if we can make those connections early on as people leave, instead of letting them get to crisis point, we're working on that early intervention, getting in there, setting them up, getting those foundations in place so that they can just transition as smoothly as possible. That's part of our goal there. And family members. We're really, really lucky with our definition of family members at the moment. There's a lot of ex-service organisations or ESOs that are quite limited. They'll only support the sort of nuclear family, so a direct spouse or a dependent child. And there isn't much else for those family members that are sort of a little bit more peripheral than that little integral unit. So we're pretty broad. We can support, parents, adult children of veterans who've passed quite a long time ago. It's anybody really that's a family member that's been impacted by a family member's service. The other things on this slide that I thought were really important to mention was what the definition of a veteran is. So there's been a few different definitions of a veteran over the years. And I think that the definition that we have now is probably the most comprehensive to capture the most people and validate their service and their journey with that. So a veteran is anybody who has served a full day, so 24 hours in service. It doesn't matter if they were deployed to see, active service overseas, whether it was peacekeeping missions, whether it was national service back in the 60s and 70s. It's if you've served a day, you are a veteran, you are eligible for support. And that's not just with us, that's across the board. So there's a lot of people who are older who don't believe that they're eligible for support and services, but have listened to us come and present, and they've sort of gone, oh, hang on a sec. Actually, I had national service back in the day, but I don't think I'm actually eligible for anything. And they've struggled their whole lives, and they've found that they are eligible to have their service recognised. That brings me down to the other point there about white cards and gold cards. So DVA entitlements are sort of ranked on their cards. If somebody has an injury and they've claimed it with DVA, it gets put onto their white card or their gold card. And depending on which one you have, you get different levels of support and entitlements. But the white card, even though it's not as comprehensive as the gold card, it is incredibly important. So one of the main things that we've come across is the need for that mental health intervention and care. And once you have your service recognised and you have a white card, then you're entitled to non-liability mental health care. So DVA will fund a psychologist, a counsellor, a psychiatrist for assessments and things like that. So there's a lot more support out there. It's really important to note that not all injuries are the same as well. So somebody who has gone overseas and, you know, they've seen horrific things and dealt with things that, you know, everyday people don't even want to talk about. And then there's people who have gone through basic training and been traumatized. Both sets of people have PTSD. Both sets of people have lasting damage that they're trying to deal with. And we're really trying to support people to understand that, you know, they're not any different. It's the same diagnosis. They are absolutely entitled to the same level of care and consideration. It's not, you know, one's more important than the other. And yeah, sorry, I know I'm waffling. I get onto these points and I waffle. So the other point that I've got in there is how important the DVA payments are for GPs, and this goes for other allied health professionals as well. So I've had a few people reach out and ask about the payments that their GP gets. They might have to co-pay, they might have to not access DVA because their GP just goes, well, it's not worth it for me. There's actually a lot of supplementary payments out there for GPs to claim on top of that other fee. So I think it's been in the last maybe 12 months, maybe a little bit more, the DVA have tripled what they were paying GPs initially. So there is a lot more information out there. It's something that we're also happy to provide where we can. My last point on that slide was, why is it important to have that service recognised? And I think I sort of deviated off my points up the top and jumped straight to that. And yeah, there's a lot of people out there who are probably of the older generation that don't believe that they're eligible for the support. We've had a couple of gentlemen in particular in their mid-80s who've come in to have help to have a white card, and all the white card does is acknowledge their service. And I think it's really important. Even if they're not after any help, that acknowledgement of service is huge. So the mode of care, like how we actually support the people that we support. So we are known as care coordinators. So we're not caseworkers, but we are care coordinators. So we do a similar kind of role to a case manager, but it's several steps back. So we're looking at what the person needs, and we're looking at how we can connect that person to those things. And that looks different for every single person. So we have these wonderful tailored care plans that we have for everybody that comes in. And we don't sort of dismiss somebody based on, you know, oh, well, you just need one small thing, or, you know, or you're too hard, you have too many things. We really do try and provide as much support and care as we can for every single person that comes in, regardless of their needs. And as far as stakeholders go, we work really, really hard to build really strong relationships with our provider database. So we like to get to know everybody in the areas that we operate in, who might have specialties in different areas, who might have experience working with veterans, or they might be a veteran themselves. They might have DVA experience. And so, yeah, we just like to sort of keep track of that, build those relationships, be as sort of open and approachable as we can be for all of our stakeholders, whether it's family members or friends or, you know, other healthcare providers. The support for our participants in general, aside from the care plan, so we might help somebody to fill out a form. You know, they might be just overwhelmed with the idea of filling out some paperwork for Centrelink. It could be something as simple as that. They could be coming in and saying, hey, I just need a GP. You know, I'm good with everything. I'm really internet savvy. I've got all my claim stuff. I'm just really struggling to find a GP with their books open right now. Can you give us a hand? So we do. It doesn't matter what it is, we'll give them a hand wherever we can. We make sure that whatever our plans entail, it's person-centered. So we let our participants drive those plans. We have a really wonderful detailed intake procedure where we go through all the different aspects of somebody's life. So we're looking at you know, where they're living, who they're living with, who their supports are, any sort of medical providers that they're seeing, any issues they might be having, and we just generally have a really good chat. So it seems a bit paperwork heavy when we sit down with somebody, but usually our care coordinators will sit there and we will fill out those forms for somebody, just having a chat. So it's not, you know, sitting there and ticking a box. It's genuinely getting to know somebody and taking that time and that care to really understand what those needs are. Sometimes we get people coming in and they think they just have one need, and then suddenly they have 10 they didn't realize they had. But after they've actually been able to talk it through with somebody, they realize that there is actually a lot more to that. So let me just skip through. Oh, we can do the care plans in conjunction with other providers too. So we do try and look at continuity of support. So if somebody's transitioning from somewhere or someone or some other provider, we really try and get those providers on board so that everybody is across what that person needs. So the communication level with providers is really quite high. We do try and engage as much as we can so that that proper level of support is there for them. So I've put together a couple little quick case studies. I know I've probably touched on a few of these points already as I was going through some stuff, but this one was just a really good example. We had somebody come in who just needed the GP, and they were really great with everything else. They just needed that connection. So we researched the GPs in their area. We reached out to them and we figured out what their specialties were, whose books were open, when their next available appointments might be, and we give that information to the person, and they reached out, they booked their appointment, everything was great, happy days, off they went. They didn't need to keep engaging. Then we have ones like this one. So this person came in at the very, very start of wanting to get their DVA claims sorted. They didn't know exactly what they needed, but they just reached a point where things were a little bit much. Every time they logged on, they just logged straight off and just couldn't deal with the My Service app and didn't know where to start. They didn't have a GP, they didn't have anything. So when they came in, we had a really good chat with them. We sat down, we figured out that the best place to start would be an advocate at one of the local RSL sub-branches. So we linked them in and we had a chat with them and the advocates, and we figured out that they needed the GP, started with the GP, and then from there they went, okay, well, we need, you know, different specialists. I can't remember which one this one is. I think it was, yeah, psychiatrist, psychologist, pain management specialist, and an OT. So by the end of it, we had everything sort of in order for them. We communicated a lot with the advocates so that that person wasn't too hassled. You know, it wasn't calls from all different people and having to set things up because that was just too overwhelming for them at the time. So it was just really great to be able to connect them to what they needed, and their mood improved so much. They went from being quite teary and easily emotional, and they were just confident by the end of it. They were able to ring providers. We would give them the options. They'd ring themselves. When we started out, we would have to ring with them and help them to set that appointment. Worth noting that we also use our K10s as an assessment tool there. So that was a really, really great opportunity for us to show our participant their progress. They were really struggling to see how far they'd come. And so we were able to show them the K10s that we do. So we did an assessment at intake, we did one partway through service, and then we did one at the end when they were ready to disengage. And we could show them how far they'd come. They could see their progress. Their scores for anxiety and depression were significantly reduced. So that was really beautiful to see. It was really nice to show them the tools so that they go, oh, okay, actually, yeah, you're right, that did work. So stakeholder engagement. I think this is one of our key things, aside from the care that we give our participants. That stakeholder engagement is so key. We want to be able to refer to providers with confidence. We want to know that we're sending people who are really vulnerable to a place where they're going to get the support that they need, and that the providers are able to give them that support. There's nothing worse than somebody coming to you and saying, hey, I need help, and you just sort of go, well, I can't help you, I don't know what to do. So we want to make sure that the providers and the stakeholders involved are well supported as well, not just the participants that are involved. So we work, like I said on the slide, constantly working to build and strengthen the relationships with our providers. So we like to have regular phone calls. We come out and meet people at their clinics. We'll catch up for coffee if that's going to be easier, and just have a chat, get to know people, and you know, make sure that those referrals that we're sending through are really strong ones. We can also do warm handovers as well. There was a gentleman that we had who was quite deep into some PTSD symptoms, and he was really struggling to connect with a new psychiatrist. And we were able to take what he'd told us and reports from a previous psychiatrist who he wasn't with anymore. And instead of him having to relive all of those sorts of traumas, we were able to sit down with a new psychiatrist ahead of time and walk them through what this person was sort of dealing with. And so he went into that appointment with confidence, knew that he didn't have to go through that again, and knew that he was just going to be supported straight away. So it's things like that where we really try and strengthen those working relationships wherever we can. We want to make sure we can provide that continuity of support. That's one of the key things for us. It's probably a good chance to mention we have a lot of participants come and go out of different mental health facilities in Sydney and Newcastle and the Central Coast. And one of the things that we do with them is providing that extra support when they come back out. So the support that they would have been getting from a case manager while they were staying there, you know, they have that when they come out. So we'll connect with the case managers or a psychiatrist or whoever their sort of main treating physician is at the time, and we'll make sure that they have those connections when they come home. So it's not just that they're sort of, you know, sent off, happy days, off you go, you cured. It's no, we know that you still need that support in the community when you go home, and we're there to try and provide that extra step of support for them so that they're not just sort of left on their own. So that'll bring us to referral pathways. So as you can see, that's our lovely referral form there. When should you refer to us? Anytime you like, anytime at all. If you find out that one of your patients is a veteran or a family member of a veteran and you think that they could benefit from the extra support, refer them over. If they're going through lots and lots of things with DVA, they're dealing with lots of different people and it's becoming overwhelming and they're already really deep into the journey, refer them over anyway. We'll see what we can take off their plate, what we can help with, what we can support you with their journey as well. It's never too early, never too late. We're more than happy to step in whenever we can. When might we refer to you? As soon as we've identified the need. So if we have somebody come in and they're struggling with the GP they have, or they don't have one, they've moved to a new area, which is another common one, we want to know that we can just dip into our little database of trusted providers and know that, you know, we can give you a call and say, hey, your book's open. Are you accepting people? Do you know of anybody else if you're not? It's genuinely one of our most common requests. We've got psychiatrist and a GP are our two biggest ones. So we will always refer wherever we can, and it's very common. So the best ways to make a referral to us, you can just pass on our details to the person themselves if they're in a position to be able to make that call, or send us an email. Or you're welcome to give us a call or an email, and we can just sort of go off some little pieces of information if we need to, if you're a bit busy. As long as we've got consent to contact, we will give them a call for you. As long as they know to expect us, then we're happy to be the ones that reach out. If you have a bit of time, if you're sitting down with somebody during a session and you have a copy of our referral form, which I'm very happy to send out, please feel free to reach out. It is really helpful for us to have as much information as we can. So we do love to have the referral form done, but it isn't mandatory. We can always help with that later on as well. I've just popped our phone number and our email address down there. All of our care coordinators do have a direct mobile number, but we have a lovely team with our parent organisation, Social Futures, who do all of our intake calls as well. So the 1-800 number, you'll get one of the lovely team. So how can we help you? How can we help providers? So one of the biggest things that we've noticed that has proven to be the most helpful is streamlining communication. We've got a lot of participants who are dealing with the NDIS, they're dealing with DVA, they're dealing with their GP, they're dealing with a physio, a psychologist, a psychiatrist, they're dealing with family members, they're dealing with everybody all at once, and it's really, really overwhelming. The other aspect of that is the miscommunication. So if there's 3 or 4 different people telling them different things that are just pretty much the same, maybe slightly different, or things that are similar, they're getting confused, wires crossed. Other providers just trying to communicate with each other with a participant in the middle, you know, things aren't getting communicated across. So one of the things that we can do is be that point of contact, and we can streamline the whole thing. Everybody gets the same messages when they need to get them, and we do a lot of the following up as well. So I know I mentioned it before, but something else that we do is helping with paperwork. So if somebody has a document that they need to fill out for DVA, we know they're long, they're confusing, they're annoying. We're pretty well experienced with the paperwork side of things, so we're always happy to pre-fill things where we can. So if a participant has a doctor's appointment coming up and they've had a report from an OT and they just need to fill out the form, attach the files, we can do all of that for them. And if there's an appointment coming up with the GP and there's information in there they're not sure of, we can help them to figure out what needs to be in there as well. Smooth pathway referrals for providers. So that was sort of what I was talking about earlier, knowing that you can actually refer to somebody and their books are open. Something that's quite frustrating in the veteran space, especially, is having a closed door. You know, when a veteran's finally ready to reach out and ask for help, they're getting too many closed doors. Somebody doesn't accept DVA, somebody doesn't have their books open. So, you know, they end up going, well, why would I bother? You know, nobody wants to help, why should I? And, you know, doctors and other providers are busy. They don't have time to sit down and call 5 or 6 different people until they find somebody who's suitable or has their books open. You just go, okay, I know this person's here, I'll make the referral. And then that person gets a closed door and it's hard. So making sure that who you're referring the participants to is quite big. It's a big piece that we've found. It really, really helps people to engage in that care and stick with it. Education for providers and participants as well. So like I was mentioning earlier again, our team has a wealth of knowledge. We're NDIS experienced, we're veteran experienced, we're DVA experienced, we're My Aged Care experienced, and we love to share that information wherever we can. However we can make people's lives easier, that's what we want to do. So we're so happy to, pass on any information. DVA have updated their rates for GPs, what extra line items you can be claiming through Medicare, anything like that, anything that we can do to really push that excellence of care for our people, that's what we're going for. We can assist with managing expectations with agencies, other providers and participants. This one's another big one, where somebody goes, well, I want this. Somebody says, well, you can have that. Another person says, no, you can only have this. We can help find the right information for that and manage those expectations, and let the participants know, well, no, this is actually how it is. Same thing with other providers. It's letting them know that, yes, you can claim that, but you need to be aware of, X, Y, Z and things like that. So we're pretty good with that, pretty well experienced with managing those expectations too. And where it is appropriate, we will try and do advocacy for participants. So obviously it's not appropriate for us to be doing that in all occasions, but where it is, we do try where we can. And we try and encourage our participants to advocate for themselves as well. Like, we really do encourage that self-efficacy when it comes to especially medical things. It's important that they can be standing up for themselves and what they need and what they want. So yeah, we're just trying to turn that overwhelm into a stress-free process where we can. This one's just a little case study. Sorry, I know it's a lot of words on the screen there. You don't have to read it all. So this person came in, they were had a one-year-old, and they were struggling. They were really, really struggling. They had a back injury and a neck injury, and they'd gotten another hernia. It ended up being the third time that actually had a hernia that needed repair. And there was also some internal damage to a scar that was quite large. And so when they went to see another specialist, they said, well, no, it's a bit out of my scope. Here's somebody else you need to go and see. They're quite experienced with that sort of thing. So when they went there, this specialist was, happy to help. These are my rates. Off we go. Let's book it in. And because they were higher than the DVA line item rate, they were initially rejected. And there was a case manager from DVA involved, and the participant, and there was childcare facility, and it was just, there was a whole bunch of things all at once, and it was really, really, really overwhelming for this person. They had quite significant PTSD. They weren't coping particularly well. So we were able to sort of step in and communicate between the specialist surgeon's office, DVA, and the participant to come to a sort of an understanding. I think it was DVA and the surgeon's office got a little bit heated there, and the surgeon was just going to cancel the surgery because they didn't get approved, and then DVA wanted, extra things from them, and there was a lot of back and forth and a lot of miscommunication happening. And so when the participant came in, they were just frazzled, and they just needed somebody to take charge of the communication because they just weren't coping. And we were able to do that. So we've streamlined everything for them. All the communication came through the care coordinator. And in the end, we ended up managing to get the surgery approved at the cost that the surgeon wanted. And this person also needed the surgery to happen at a hospital that surgeon didn't actually operate out of, because it was significantly closer to home. And with the little one, it was a really big factor. So we were able to advocate and communicate and coordinate and do everything for this person. And in the end, it was a beautiful, beautiful outcome. So they're booked in for the surgery any day now, and everything is so much better for them at the moment. So GPs, worth their weight in gold. everybody needs a good GP, and as soon as you ask anybody if they've got a good one, whoever has a good one is going to be so vocal about it, but everybody's really vocal about the ones that don't do a good job either. So it's incredible to find the good ones, and that's what we want to do. We want to make sure that the GPs that we send our participants to know what they're doing, and having that knowledge and understanding is so incredibly important when it comes to veterans, because they have so many complex layers to the care that they need. They're not as straightforward as anybody else that just sort of comes in. It'd be as complex as working with first responders as well. So I'm sure everybody's heard stories about, a good experience with a GP, and everybody's heard stories about the bad experiences with GPs, and it really does stick with people, and it really makes an impact on people's lives when they have a good or bad experience. And it's so important for GPs to have the trust of the people that they're treating. Because like I put on the slide, they're the gatekeepers to that further healthcare. If people want to actually improve their health, work on injuries or illnesses, they need to be seeing a GP to make those connections, and having that trust and confidence to be able to go back and say, hey, you helped me with this, can you help me with this one now? And knowing that that they can trust what they're saying. And that's one thing that we've found in the veteran space especially, is how important trust is. It is so incredibly important. There's so many Facebook pages where veterans get together and swap stories and say, hey, does anybody know a good GP? Does anybody know a good psychiatrist? Does anybody know a good OT? And once somebody's found a good one, that name goes far and wide, and you will get inundated with other people wanting to come and see you, because you've proven to be trustworthy and understand the journey, and be supportive of veterans. So this one's just another little case study. Again, sorry about all of the text on the screen. So this participant came in requesting a new GP. The one that they were seeing, they felt wasn't supportive. So they'd recently discharged. Their injuries were all well documented in their med docs from ADF, but the GP wasn't supportive of continuing treatment outside of that space, and this person wasn't able to afford treatment on their own, and so the injury just got worse and worse. Once we were able to find them a GP who was supportive and was able to help them with the DVA paperwork, the injury claim went in and they were able to access PAMPT. So PAMPT is the Provisional Access to Medical Treatment. So that's a program run by DVA where they will provisionally fund treatment for a certain list of injuries. I think it's sort of 10 or 12 different things that they just automatically accept. And you can have treatment while your claim's being processed, regardless of the outcome. So that person was able to access treatment. They were doing a lot of physio. I didn't pop it in there. They ended up doing quite a lot of physio, and they were seeing a pain management specialist, and they were just making real progress. And they're still waiting for the claim to be approved at the moment, but they're able to access that treatment straight away. And if they'd been able to access that treatment early on, when they'd freshly discharged and the injury wasn't quite as bad, it wouldn't have been such a long journey for them to come back from that. So it's just something to keep in mind. The paperwork might be a little bit heavy and confusing and frustrating, but it is so important to properly understand that journey. Linking agencies. So like I've mentioned, we're really experienced with the NDIS, My Aged Care, DVA, and they can all coexist. So not a lot of people know and understand the way that the different systems can work together. So DVA and NDIS can exist for one person at the same time, and they actually fit really well together to fill gaps. So the DVA funding stream will fund a psychiatrist, whereas the NDIS won't fund a psychiatrist, they'll only fund a psychologist. and little things like that. So we really like to work with our participants and our providers where we can to understand how the different systems can work together. NDIS and My Aged Care, they can't work together, but DVA and My Aged Care can work together. As long as services aren't doubling up, as long as we're filling gaps instead of overlapping, then they can coexist beautifully, like filling in all of those blanks and giving a much more holistic level of care to the participants. And the other thing that we're really proud of doing is connecting to social and community services as well. So connecting people with their community is huge, whether it's, you know, finding a special interest group, whether it's linking them in with something like Invictus Australia so that they can participate in sports, finding just a general sports club that might suit their needs, or, you know, even just a mother's group for some people. It's a really big thing when somebody leaves the ADF. They lose a lot of community, so they lose a lot of the people around them, and quite often they'll move around different areas and they don't know people, and they lose that connection, and then they become isolated, and then that impacts on their mental health. So making sure they're connected is a really big piece of the puzzle there. So some of the different community connections we like to make. First and foremost, we love connecting with the general community. So not just paid supports, but community centres. So we do have people that come to us who are homeless or they're really struggling. We like to be able to link them into whatever services can help them with, whether it's food or vouchers for helping with electricity or household bills. They might be struggling to furnish their house if they've just moved. RSL sub-branches are another really good one. I know there's a lot of stigma around some of those sub-branches and the sort of culture of some of the older veterans and, you know, just going there for a beer, but they're so wonderfully helpful. They really are. They're there to support their members. So somebody who's really struggling, whether it's financially, whether it's with material things, whether it's for mental health, there are people there to support them that are outside of the RSL space. There's a sub-branch and there's an RSL, and they're different. But there are supports there for people, and we've made some beautiful connections with the sub-branches around the areas. The other one that we've really tapped into are some local businesses. So something that we've noticed was that there's a lot of younger veterans opening smaller businesses, and they're not really identifying themselves as veterans. And you just sort of find it out just casually through chatting to somebody, or, you know, somebody knows this person and, oh yeah, no, I heard that they were a veteran. And so, you know, we'll reach out to them and touch base with them, and quite often they love to give back to the veteran community themselves. They want to be doing something for their fellow veterans. We found that quite acutely with our Veteran Health Week event that we had last year, where we connected with a local CrossFit gym who was that was owned and run by a veteran and his lovely wife. And they were just so excited to open the doors and put on an open day for veterans, and it was so welcoming and so nice, and it was such a great way to build community. So we're looking at doing all sorts of different special events throughout the year, not just sort of one-off here and there. We've just made a really great connection with the Invictus Australia group, and we'll be doing a walking group on the Central Coast, you know, just bringing people together, having them, you know, enjoy each other's company, find a bit of mateship, have that connection. There's a few other ex-service organisations, the ESOs, that we do like to work with, and yeah, as soon as we build those connections, we strengthen them, we work on them, and we try and refer where we can and just support each other. How can you guys be involved? So you can register your interest or experience with us. Just send us an email or give us a call. Let us know where you are, where you're from, what your interests are, what your experience is, what your availability is like. or if you just have any questions in general. Like if I've said anything and you think, oh, I don't know about that, give us a call. We can have a chat. Happy to answer any questions you've got as well. We're also really happy to come out and do an in-person visit too. So whether it's one of us or our whole little team comes out, we can answer questions, have a chat, get to know you guys, and we'll bring a whole bunch of flyers with us. You can have them in the office set up, and hopefully they can reach as many people as they can. And I'll just pop down details down the bottom there. And then that brings us round to questions. Mel, did we have any questions in the chat or anything at the moment?
I think your presentation was so amazing, Ellie, that there's no questions. Not that I can see anyway, that's come up on the system. So you've done really well.
Well, yeah, I might
Thanks
just
so much, Ellie.
leave it.
That was, sorry. That was fantastic, and I agree with Melissa. I think that you've just covered everything so well that nobody had to ask anything. Please don't hesitate. I know you all have my email, that you can send me through anything, and I can forward it on to Ellie or Melissa if you do have anything that you think of later on. Erica is just going to give us a quick Health Pathways update.
Thank you. I'll just share my screen. Is that sharing my screen, Jenny?
Let me just quickly fix that up for you.
Thank you. Is that all right now?
Yes, I
Great.
can see your slides.
Pop into
Just need to start the
presenter.
slideshow.
Yep. Just moving my panel there. Okay, here we go.
Perfect.
All right, so yeah, thank you for having me. I'm representing both Hunter New England and Central Coast Health Pathways teams tonight. So on the screen, we've got the both websites for health professionals and then also the patient information websites as well. And you can just click on those QR codes if you want to go directly to the home pages of both sites. Or these slides will be up on the Education Library, as Jenny said, in a few days' time, and you can click directly to the links there. Okay, so on the Central Coast, so each website, both HNE and Central Coast, have a section for veteran health, and it's in the specific populations section in the left toolbar, or you can just search veteran for in the search bar. So we've got a veterans health assessment clinical pathway, a veteran referral and support page, so for referral information, and then on the Central Coast we've got a Department of Veterans Affairs general information page as well. And another page that I thought would be relevant to this presentation tonight as well on the Central Coast is social prescribing page. So that covers, I guess, a lot of the social determinants of health and how linking veterans with social support that was talked about earlier as well by Eleanor is really beneficial for their mental health too. So then also on each website as well, you can click on the daily updates page, and that just summarizes recent changes that have been made. So just keep an eye out on that page regularly, and you can see what's changing over time with new pathways. It just gives you a quick summary of what's changed. And then Hunter New England similarly, so Hunter New England also has the veteran health section, and they have the Veterans Health Assessment clinical pathway and the veteran referral and support. I'll mention that the Veterans Health Assessment page is a lead region page developed by the Townsville Health Pathways team. And so Central Coast Health Pathways, Hunter New England Health Pathways and Townsville Health Pathways teams, along with Department of Veterans Affairs, have been working together on a Veterans Health Pathways national project together for about the last 2 years. And so Townsville has been the lead. Obviously, they have the base up there, so they have a very large cohort of veterans in their community, and they have some GPs who are really well experienced in working with veterans. So we've leveraged their kind of experience and knowledge, and they've led the development of the pathway, but also got contribution from a number of pilot regions, including Central Coast, Hunter New England, and some other regions across Australia, to develop a standardised national pathway. That's the clinical pathway. And then the referral page has some standardised information of national and statewide services, but it also allows each region to have some localised local service information as well. So I'll share my screen. Hopefully I can swap to our website now, but I'll just try that and just see if it works. Jenny, is that showing Health Pathways now?
Yes, it is.
Excellent, great. Okay, so this is the Central Coast homepage for Health Pathways. So either you can navigate down to the specific populations section and then expand that, and then expand veteran health. Click on the contents page, and then these are the pathways for Central Coast, and it'll have the same format on Hunter New England as well. So this is what the clinical pathway looks like, and so that's the same. If regions choose to adopt the national pathway, they can adopt the veterans pathway that Townsville and the joint project developed, and this has had input from DVA. So it's up to date and has had good consultation with multiple different regions and DVA. So then specifically regarding the referral page, I thought this would be very relevant to our participants tonight. So on the, this is partly the national page, so it's got national and statewide information, but there's also some local services on there too. So I'll just scroll down. It's got some information about Medicare funded, DVA funded, and then private options. And then we've got all of these sort of other relevant services and supports that a veteran patient or their family might be able to access. And in terms of Veterans Connect, we've got that in the social and wellbeing section. So we've got a specific section for Veterans Connect, and then that links through to the page on the Social Futures website. So I just wanted to sort of show you that we've got as much relevant supports and services available as we can on these pages. But on each page, on all Health Pathways pages, there's a little send feedback button. And if you identify services that we need to add, or an email address that we need to update, any sort of feedback, you can click on that, enter your email address in there, and then it clicks through to a little pop-up box that's just like an email. You can send your feedback. It will let us know which page you sent the feedback on, and it comes through to our program teams. So it'll come through to either Central Coast team if you're on that website, or the HNE team if you're on that website. And then our teams will follow up on that and make amendments as needed if there's new services that we need to add. So I'll just see if I can pop back to my final slide and share that. That's all. If you needed to contact us on the website, just search for Contact Us, and there'll be our contact details on each of the websites. Thank you very much. Jenny, did we have any questions? doesn't look like we've got any.
We do have a
Oh, you
question.
do. Great.
Actually, no, it's just a comment. And great presentation. I will provide your contacts to my veterans that need support.
Oh, that's great.
So that's exactly what we wanted.
Thank you.
Well, thank you so much,
Lovely.
ladies, for giving up your time, and thank you everyone who's attended. Don't forget, there will be a copy of this wonderful webinar in our library along with a PDF copy of the slides. All right, good night everyone, and I'll see you next time.
Bye guys. Thanks.